Thanks for the organizing committee for the opportunity to present our work. So let me introduce some background in the field. Some, but not all, past cohort studies have suggested higher mortality among African Americans and Hispanic patients than among white patients with SLE. These studies had been mainly based in academic centers such as Toronto, Baltimore, or even multicentric studies such as Lumina or SLEEK, but they have relatively few deaths, and they do not provide large population-based estimates of SLE mortality rates or annual mortality rates. There is only one study made by CDC that reports significant differences by age and race in mortality rates among SLE patients older than 15 years between 1979 and 1998. In that study, mortality rates were highest among African American and patients older than 45 years old. However, mortality rates among U.S. SLE patients had not been reported recently. For those who are not familiar with Medicaid, Medicaid is a health insurance program run jointly by the U.S. federal and state governments. Medicaid includes the largest health insurance program in the U.S., covering over 62 million Americans and providing health and long-term care coverage for low-income families. The Medicaid covers 1 in 5 Americans and also covers more than 1 in 3 children in the U.S. Our aim was to examine mortality rates overall and by age, sex, and race and ethnicity among SLE patients enrolled in the Medicaid in the U.S. from 2000 to 2006. We use Medicaid analytic extra data containing all billing claims for Medicaid patients in 47 U.S. states and D.C. From 2000 to 2006, we identified patients older than 3 years, between 3 and 65 years, with prevalent SLE defined as more than 3 criteria and more than 30 days apart, as well as those with lupus nephritis defined as more than 2 additional ICD codes for nephritis, renal insufficiency, or renal failure. We also include demographic data, including age, sex, race, ethnicity, and region of residence in the U.S. We calculate annual mortality rates with 95 confidence intervals as deaths per 100,000 Medicaid patients with SLE in each socio-demographic group in each year. We calculate the t-test to compare differences among groups. We also made a stratified analysis by age, sex, race, and ethnicity, and we calculate the Cochrane-Armitage test for trends. As you can see here, we identified more than 43,000 patients with prevalent SLE with a mean age of 37 years. Most of the patients were adults, and as expected, most of the patients were female patients. 22% of them suffered from lupus nephritis, and most of the patients were African Americans and white patients. Regarding the region of residence in the U.S., 38% of them live in the South, 22% in the West, 21% in the Northeast, and 19% in the Midwest. You can see here in this slide, we found a total number of deaths of 2,255, representing 0.5% of our entire cohort, with an overall annual mortality rate of 983 per 100,000 patients. As you can see here, we found during the last period of the study a slight decrease in mortality rates during the last 2 years of the study. So also we analyzed by sex in the horizontal line by sex, and here deaths per 100,000 patients per year. And as you can see clear that male patients had higher mortality rates than female patients. We also analyzed by age group, divided in patients between 3 and 14, patients between 15 and 44, and older patients between 45 and 65. And as expected, younger patients had lower mortality rates than middle-aged patients, and older patients had higher mortality rates than middle-aged patients. We also analyzed by race and ethnicity. As you can see here, that African American, natives, and white had higher mortality rates than Asian and Hispanics. For example, if you check, African Americans had almost 6 times higher mortality rates than Asian patients. There are 3 important messages in this slide. The first, you can see in the red line that male patients had higher mortality rates over years. This line was, the second message, the line is unstable, or at least less stable than female line, but this is explained because we've had fewer cases as a male patients, but we didn't find any differences in the mortality trend over time regarding the sex. Moving to the age group, once again, older patients had higher mortality rates than middle age group and younger patients, but important, we found a slightly decrease in mortality rates during the last 2 years of the period in this particular group of patients between 15 and 44 years. So this is good news for this particular group of patients. Once again, African patients represented in red, white patients represented in blue had higher mortality rates than Asian and Hispanic patients. Let me explain here, just for female patients, we analyzed the mortality rates by age and age. And in black line, you can see black or African American patients had just slightly higher mortality rates than white patients. Of course, we have some strengths and limitations. As a strength, we have a large sample, including more than 40,000 SLE patients, providing power to detect differences in annual mortality rates according to age, sex, and race and ethnicity. And we have data over recent 7 years period in a diverse patient population. Of course, we have limitations, including we don't have information about disease severity or disease activity. Maybe there is an option of misclassification by race or ethnicity, and the Medicaid population may be not generalizable to other populations abroad or generalizable to population with higher socioeconomic status. We have some future directions. We have to analyze or calculate a fully age, sex, and race and ethnicity adjusted mortality rates and rates ratio. We have to calculate the standardized mortality rates compared to the entire U.S. Medicaid population. We also have to analyze the causes of death, and in the long term, to understand factors including access to quality health care, which contribute to observe racial and ethnic disparities in mortality among SLE patients. To conclude, we can say among more than 43,000 patients with lupus over 7 years across the U.S., we found marked age, sex, and race and ethnicity specific differences in mortality rates. Annual mortality rates among SLE patients with Medicare were highest among African American, Native American, and whites than Asians and Hispanic, were higher in men versus women, and were highest in patients over 45 years. We also can conclude that among SLE patients between 45 to 65 years, African American women had only slightly higher mortality rates than white women, and finally, annual mortality rates remain stable over 7 years of the study, and we only find a slight decrease in mortality rates among 15 and 44 years group. Let me thank our supporting institution, including NIH and Fundación Alfonso Martín, and also want to thank my mentor, Dr. Karen Kustenbade, for her advice and help. Thank you.
We have time for one question.
Yes.
So, of course, you have mentioned yourself the limitation in terms of Medicaid data, but as in general clinical practice, we know that the mortality or morbidity in Hispanic patients is much more higher than other ethnic groups. Could it be because they don't have Medicaid, or, because these data does not correlate to what we see more clinically, though?
So if I understand the question is, the Hispanic patient had, higher mortality than other races included in this case in the Medicaid population. In fact, this is a possible limitation from our study. You know, Hispanic concept is something like a heterogeneous concept that includes many kind of people living in the U.S. with a Hispanic background. But in general, it is different to be Hispanic. For example, for instance, Lumina cohort have that information, for instance, from Texas to Hispanic coming from Puerto Rico. So it's true, this concept in this particular database of Medicaid, Hispanic patients are classified as a whole group, but certainly it's a heterogeneous group. So we have to take, some care about these conclusions about mortality in Hispanic patients. I don't know if I answered your question.
Thank you.
I have a question. You did notice, I did notice in your limitations that you want to calculate the adjusted rates against ethnicity. And I think that would get rid of some of this problem because in general, even in healthy people, African American as well as Native American mortality rate is higher than other ethnicities in America. And that might be the reason why you're seeing such a skewed annual mortality rate, because this is not disease-specific mortality rate, this is just annual mortality rate. And annual mortality rate in African Americans and Native Americans is higher than whites or Asians in America.
Yeah, it's true, but there is also a concept known as a Hispanic paradox, and we don't know why, even if the Hispanic patients have a higher burden of disease, overall a higher, accrual damage, mortality rates are not as high as other populations. But of course, this is a very vulnerable population, low-income population with some specific characteristics, and all the conclusions not be, extrapolated to other populations. Absolutely.